On the endocrinology ward, two individuals came in. The first one is 55-year-old Gregor, who came in complaining about weight loss, heat intolerance, chest pain, palpitations, and insomnia. On the clinical examination, he's anxious and restless. He also had warm and moist skin, his eyelids were retracted, and there was exophthalmos of both eyes and tachycardia. The other person is 37-year-old Josie, who migrated to the US from Panama. She came in with similar symptoms as Gregor, but on clinical examination, she also had a goiter. According to her, she recently had a contrast imaging procedure for a different problem. TSH and levels of T3 and T4 were taken for both individuals. Levels of TSH were low, while levels of T3 and T4 were high. Okay, so both individuals had hyperthyroidism. First, a bit of physiology. Normally, the hypothalamus detects low blood levels of thyroid hormones and releases thyrotropin-releasing hormone, or TRH, into the hypophyseal portal system. The anterior pituitary then releases thyroid-stimulating hormone, also called thyrotropin, or simply TSH. TSH stimulates the thyroid gland, which is a gland located in the neck. The thyroid gland is made up of thousands of follicles, which are small spheres lined with follicular cells. Follicular cells convert thyroglobulin, a protein found in follicles, into two iodine-containing hormones, triiodothyronine, or T3, and thyroxine, or T4. Once released into the thyroid gland, these hormones enter the blood and bind to circulating plasma proteins. Only a small amount of T3 and T4 will travel unbound in the blood, and these two hormones get picked up by nearly every cell in the body. Once inside the cell, T4 is mostly converted into T3, and it can exert its effect. T3 speeds up the cell's basal metabolic rate. T3 increases cardiac output, stimulates bone resorption, thinning out the bones, and activates the sympathetic nervous system. Thyroid hormones are also involved in a number of other things, like controlling sebaceous and sweat gland secretions, hair follicle growth, and regulating proteins, as well as mucopolysaccharide synthesis of skin fibroblasts. Now, hyperthyroidism can happen a few different ways, and all of them result in too much thyroid hormone and a hypermetabolic state, where cellular reactions are happening faster than normal. First, hyperthyroidism can be primary, in which case the thyroid gland is the problem, and it's making too many hormones. There are a few specific diseases associated only with hyperthyroidism, but sometimes diseases like thyroiditis, which damages the thyroid and causes hypothyroidism, can cause stored thyroid hormones to leak out, resulting in an initial period of transient hyperthyroidism. Then there's secondary hyperthyroidism, where the problem is increased TSH secretion due to a problem with the pituitary gland, like a rare TSH secreting adenoma. Now let's talk about some of the causes of primary hyperthyroidism. Graves' disease is the most common cause of hyperthyroidism, which can sometimes manifest during periods of stress, like during pregnancy. This is an autoimmune disorder where B cells produce antibodies against several thyroid proteins. The most high-yield autoantibodies you need to remember are thyroid-stimulating immunoglobulins, which are a type of G immunoglobulins that produce a type 2 hypersensitivity reaction. They bind to the TSH receptor on follicular cells and imitate TSH. This results in growth of the thyroid gland and stimulates the follicular cells to produce excess thyroid hormone. Now, these autoantibodies can also cause Graves' ophthalmopathy. These antibodies activate the T cells in the retroorbital space, causing them to secrete cytokines like TNF-alpha and IFN-gamma, which increase fibroblast secretion of glycosaminoglycans, which ultimately increases muscle swelling, muscle inflammation, and increases the adipocyte count, leading to exophthalmos, which is anterior bulging of the eyes. Now, thyroid-stimulating immunoglobulins can also increase the activity of dermal fibroblasts, resulting in pretibial myxedema, which is the classical finding of waxy lesions with non-pitting edema that usually appears first on the lower legs. Now, there's a gene complex involved in the regulation of the immune response, and this is called the human leukocyte antigen system, or HLA system. Interestingly, individuals with Graves' disease often have specific HLA genes such as HLA-DR3 and HLA-B8, which are important clues on your exams. Histology of the thyroid will show tall and crowded follicular epithelial cells with scalloped colloid. Another cause is toxic multinodular goiter, where one or more follicles starts growing bigger and generating lots of thyroid hormones independently of TSH. A high-yield fact is that in about 60% of the cases, this happens due to mutations in the TSH receptors that inappropriately keeps these follicular cells active. On histology, this appears as focal patches of hyperfunctioning cells with a lot of colloid inside. Now, nodules that produce a lot of thyroid hormones are called hot nodules because they show increased activity on radioactive iodine uptake tests. Fortunately, they are rarely malignant. Another high-yield concept is the Jod-Basedow phenomenon, or iodine-induced thyrotoxicosis. The Jod-Basedow phenomenon is hyperthyroidism that happens shortly after administering iodine, even in the form of iodine IV contrast. The phenomenon does not affect people with normal thyroid function, but will affect individuals that are iodine deficient and have a goiter, or in people with Graves' disease, toxic multinodular goiter, or thyroid adenomas. The key point is that all of these disorders have autonomous thyroid tissue that act independently of TSH regulation. So, when there's extra iodine, it provides more material for thyroid hormone production without negative feedback from decreased TSH. You can think of the Jod-Basedow phenomenon as the opposite of the Wolff-Chaikoff effect, where a large increase in iodine actually leads to temporary decrease in thyroid hormone synthesis. Regardless of cause, symptoms of hyperthyroidism are similar, and remember that with hyperthyroidism, everything goes faster. Metabolic findings include heat intolerance, weight loss, and increased sweating, due to an increased basal metabolic rate. The skin can be warm and moist, mostly due to vasodilation and increased sweating. The hair is fine and friable, while at the same time there's onycholysis, where the nails separate from the nail bed. Ocular findings include lid lag or retraction, and this happens due to increased sympathetic stimulation of the levator palpebrae superioris muscle. In Graves' disease, there's also Graves' ophthalmopathy. Finally, long-term hyperthyroidism can increase the risk of bone fractures since T3 increases bone resorption, leading to osteoporosis. Gastrointestinal findings include diarrhea and hyperdefecation due to increased gastrointestinal motility and the appetite is increased. Musculoskeletal findings include thyrotoxic myopathy, which usually manifests as proximal weakness, but levels of CK are normal. This probably happens because thyroid hormones interfere with cell metabolism, including muscle cell metabolism. Reproductive findings include oligomenorrhea or amenorrhea, low libido and infertility in females, and gynecomastia in males. One of the mechanisms involved is that with hyperthyroidism, there's also an increase in sex hormone binding globulin, or SHBG, and as a result, levels of total testosterone, dihydrotestosterone, and estradiol are increased, and this can interfere with normal hormonal processes. Regarding menstrual disturbances, the mechanism involved can be that thyroid hormones interfere with GnRH signaling, which in turn affects LH and FSH pulses. Neuropsychiatric findings include hyperactivity, restlessness, anxiety, insomnia, and this is due to increased beta-adrenergic activity. Additionally, reflexes are brisk. Cardiovascular findings include tachycardia, palpitations, dyspnea, arrhythmias, chest pain, and systolic arterial hypertension. And these are all caused by increased activation of beta-adrenergic receptors and increased expression of cardiac sarcolemmal ATPase, which allows the heart to contract faster. There's also decreased expression of phospholambin, which is a protein that regulates the calcium pump in cardiac muscle cells. Okay, finally, let's talk about thyroid storm, which is a rare but life-threatening complication of hyperthyroidism, where the body goes into a state of severe hypermetabolism. This can happen when hyperthyroidism isn't treated or isn't completely under control, and can worsen during acute stress such as infections, trauma, and surgery. All of the normal symptoms of hyperthyroidism become exaggerated, and the individual presents with fever, tachyarrhythmias, agitation, delirium, and even coma. Diagnosing hyperthyroidism is done by measuring blood levels of TSH, T3, and T4. If it's due to a primary cause, TSH will be low, and unbound thyroid hormones will be high. This should be one of the first things you consider when you encounter a hyperthyroid problem on your tests. Once hyperthyroidism is confirmed, a radioactive iodine uptake test and a thyroid scan can help determine the specific cause of the disorder. There's diffuse uptake in Graves' disease, patchy uptake in toxic multinodular goiter centered around each nodule, and decreased uptake in thyroiditis. For secondary causes, if TSH level is normal or high, this points to a pituitary tumor, which can be confirmed with an injection of thyrotropin-releasing hormone. Treatment of hyperthyroidism involves beta blockers like propranolol in order to reduce the effects of thyroid hormones. There's also propylthiouracil, which decreases thyroid hormone synthesis, and corticosteroids like prednisolone to inhibit T4 to T3 conversion. Finally, there's potassium iodide, also called Lugol solution, which can cause decreased thyroid hormone synthesis via the Wolff-Chaikoff effect, and it also decreases vascularization in the thyroid. Propranolol, propylthiouracil, and corticosteroids are all used as first-line treatment of thyroid storm, while Lugol solution is used as a second-line treatment. Alright, as a quick recap. Hyperthyroidism can happen a few different ways, and all of them result in too much thyroid hormone and a hypermetabolic state. Symptoms of hyperthyroidism affect multiple systems. Metabolic findings include heat intolerance, weight loss, and increased sweating. Skin and hair findings include warm and moist feel of the skin, fine and friable hair, and onycholysis. Ocular findings include lid lag or retraction. Gastrointestinal findings include diarrhea and increased appetite. Musculoskeletal findings include thyrotoxic myopathy. Reproductive findings include oligomenorrhea or amenorrhea, as well as low libido and infertility in females, and gynecomastia in males. Neuropsychiatric findings include hyperactivity, restlessness, anxiety, insomnia, and brisk reflexes. Cardiovascular findings include tachycardia, palpitations, dyspnea, arrhythmias, chest pain, and systolic arterial hypertension. With primary hyperthyroidism, TSH will be low and unbound thyroid hormones will be high. But with secondary hyperthyroidism, TSH is normal or high. Regarding causes of hyperthyroidism, Graves' disease is the most common. Other causes include toxic multinodular goiter, thyroiditis, and Yod-Basedow phenomenon. A thyroid storm is a rare but life-threatening complication of hyperthyroidism, where the body goes into a state of severe hypermetabolism. Okay, back to our cases. Gregor came in with classic symptoms of hyperthyroidism, like weight loss, heat intolerance, chest pain, palpitations, insomnia, anxiety, restlessness, moist and warm skin, and retracted eyelids. Labs confirm that he's suffering from hyperthyroidism, and the exophthalmos points towards Graves' disease. Josie came in with similar symptoms of hyperthyroidism that were confirmed by lab tests. Given the history of recently having a contrast imaging procedure done, probably with iodine contrast, we can assume that Josie might be iodine deficient, the likely cause of her goiter, and probably suffers from Yod-Basedow phenomenon.